it's time that we did something to recognize the contributions of Bill Dolan. And they wrote a check and said, now go match the money and let's do something to honor Bill Dolan. So they challenged us, and we went out in the community, and we began to talk to Bill's friends, of whom there are many. They all had heartwarming personal stories on Bill Dolan, how he touched their lives, meeting them in the emergency room in the middle of the night when the kids were hurt, or advising them when serious illness threatened about what course the family should take, urging them to make Arlington their home, and on occasions urging them not to make Arlington their home. That type of advice, as you can understand, was all given in a quiet, subdued tone. The contributions of these people were generous, and frequently when we talked to his friends, they gave us names of other friends who had equally heartwarming stories. So we're grateful to all of you and to Bill's family, who participated generously in this endeavor. Of course, when we were finished, we had raised $275,000. And what to do with that kind of money, we had to look for some real professional advice. And we looked to Dolan, who's got a lot of advice anytime you would like to ask. But he was the catalyst for us getting involved in something with medical education, because Dr. Dolan has been Mr. Affiliation for many, many years. So his greatest interest was medical education. And I would just like to digress for a minute to a special welcome to Christine, Mrs. Dolan, Jeff and Bill, Carol Dolan. John is traveling in his job, and to Alexandra Stoddard, a grandchild who is here with us. And I'd also like to welcome John Griffith, the Chancellor of the Medical Center at Georgetown, who takes our money every year. But we'll welcome you here, John, and the affiliation has been a marvelous thing over these years. Thank you for coming, and it's my pleasure to introduce the Arlington Hospital Foundation President and CEO, Jim Reeder. Jim?
Thank you, Ken. It is truly indeed an honor for me to welcome all of you to the 4th Annual William Dolan Lecture. This is my 3rd, in fact, since I've been here just in time for the first one when I first arrived a few years ago. Bill Dolan, as you know, is as close to the heart of the Arlington Hospital as one can get. He has been here almost since the day the hospital opened its doors. His commitment to this institution, our patients, and our medical staff has been a driving force in the growth and success of this hospital. We are working very hard to ensure that we continue Bill's tradition of setting the highest standards of excellence at Arlington Hospital. We will want the best facilities, state-of-the-art equipment, and professional service possible. In the face of the very difficult economic conditions and changing regulations that lie ahead, maintaining those standards will require a real commitment from everyone involved in our hospital today, the medical staff, administration, and of course the members of our Board of Trustees. I am proud and very proud of the cooperation and teamwork that I have seen displayed here in the last couple of years. We have made hard decisions and compromises in our budgeting processes. We have and will continue to work together to address the special challenges of managed care. We will strive for excellence in the spirit of cooperation as the year goes forward, because our ultimate concern is quality patient care. Nothing is more critical to the patient care than education of our physicians. And thanks to the generosity of those of you who created this endowment, we are able to honor Bill by bringing an outstanding speaker to further the education of the Arlington Hospital medical staff each year. So without any further delay, let me ask the president of the medical staff, Dr. Bob Ryan, to come on.
Then I'm going to give a quote from Dr. Lundberg just to open this. And he said at that time, if the Iron Curtain can be lifted, if the Warsaw Pact dissolved, and if East and West Germany can be reunited, and all quite rapidly, because it's the right thing to do and the time had come, surely we in this rich and successful country can manage to provide basic health care because it is the right thing to do and the time has come. And I think with that quote, it will help us introducing this topic. His topic tonight actually is preserving medical professionalism, which obviously is a topic very close to all of us here, particularly in these times when we're struggling with managed care, cost containment, health insurance companies, and so forth, and ways of providing care to all patients. I'm not going to read the long litany of his honors and accomplishments. They're too long, but you can read it in the program. It's a pleasure for me to introduce to you Dr. George Lundberg. Dr. Lundberg.
Dr. Ryan, President Reeder, Dr. Dolan, Mrs. Dolan, family and friends of Bill Dolan, fellow physicians and guests, good evening. I consider it an honor and a privilege to have the opportunity this evening to address this important gathering in what has become a tradition, the 4th Annual William D. Dolan, M.D. Lecture. By good fortune and by friendship, I've been able to attend 3 of these, and my wife has been with me for 2 of them. Both my wife Patricia and I have known and respected Bill Dolan for a very long time in the field of pathology, and that provides a particular joy in being able to assist in honoring him once again this evening. As you know, I'm a pathologist, so I will, of course, be working from slides. But none of those kind of slides that he's been showing you all these years. Very, very different kind of slides because it's a very different kind of subject this evening. May we have the lights down just in the very front and the projector on. I'll turn it on and we'll start to work. I believe that in developed countries, the golden age of medicine is at hand for the patients, not necessarily for the doctors, and then only for those patients who have good, comprehensive health insurance. Among our salient achievements have been huge advances in science, abundant technology, some say too much, excellent facilities almost anywhere you go in our country, enough physicians to take care of all of our people well. It may be that they're not in the right field or in the right location, but there are enough of us to take care of all of our people well. I say adequate funding, although there may not be another person in the room who agrees with me. $738 billion this year, 12.5% of our gross national product, and $2,500 per year per person is a hell of a lot of money, and more than any other country in the world by far in any of those criteria. It may not be divided up right, but there's enough of it, I think. We still have pluralism in the delivery of care, and if we take care of our professional elements properly, we will retain pluralism. If we don't, we won't. We are in an era of rapid communications and computers in medicine. We have the benefit of constructive entrepreneurialism, which I like. We're emphasizing prevention of disease, and we are applying scientific management principles, perhaps for the first time in medicine. We should be very, very pleased. The Institute for the Future in Menlo Park, California, has identified these 12 technologies which it says are going to define technologic medicine for the rest of this century. They are computers and communication, transplants, artificial organs and prosthetics, magnetic resonance imaging, monoclonal antibodies and DNA probes, endoscopy and in vivo monitoring, home diagnostic tools, drugs, vaccines, and drug delivery, human gene therapy, mental health as a technology, lasers, surgical advances of various kinds, and positron emission tomography. Now, imagining full implementation of all of these technologies just in developed countries is mind-boggling and will break the bank of any nation that tries it. I define management as the recognition, harnessing, and channeling of all available appropriate forces and resources towards meeting defined goals and objectives. It's my definition of management. Management looks like this, theory and practice. The background is the hard line checkerboard. That's the theory of management. The foreground is the practice of management in many of the places that I've been. When I painted that painting in the West Texas desert in 1965, I called it Army Administration. I know we're near the Pentagon, but I was in the Army for 11 years, and I knew what I was painting about at that time. Subsequently, I called it Los Angeles County Administration. Later, I called it University of California Administration. I would never call it American Medical Association Administration, at least not as long as I'm in my current job. There may come a time when I will call it that. Now, if you don't hear anything else tonight, I hope you will hear this, because among our greatest medical achievements, we have done the following. And I credit this to Dr. Bill Foege, who is currently head of the Carter Presidential Center in Atlanta, was the director of CDC for many years, and he's on our JAMA editorial board. For every one day that has passed since the year 1900, we as a civilization have added 7 hours of life to the average expected lifespan at birth of an American. 7 hours added for every 24 hours lived in this century. An incredible modern American achievement. Again, we should be very proud. And yet many things stand between us and any ideal medical system of the future. Much of what I'm going to talk about are problems, but I've started the talk by saying we're terrific. We've done a great job, we've done things very well, and we can prove it. Now let's see how we can continue to do that. All of us have our favorite list of problems that we deal with in medicine these days, problems that are important, pressing, timely, that stand in our way. I could probably get 100 different problems from the group assembled here. I have my favorite list of 16, which I'd like to share with you. They are the increasing percentage of the gross national product spent on medical and health care, entrepreneurialism, business versus professionalism, greed, conflicts of interest, hucksterism, failure to listen to patients, failure to listen to the public, failure to care adequately for the poor. That's the first 8. Implicit rationing of medical services, prolonging dying, insufficient preventive medicine services, although we're doing better, conspiracy of silence with biased expert testimony in court still, although we're doing better, questions about quality of care, burying our mistakes without really learning from them. I don't know about Virginia, but in Chicago, the autopsy rate in hospitals across the board, 86 hospitals, is 12%. You take out the teaching hospitals, it's under 10, and many it's under 5. And the hospital in Chicago that has the largest number of deaths has the lowest autopsy percentage. And I think that's a real problem. And with this burying our mistakes without studying them, we have the public's increasing lack of trust in the profession and professional liability, which is a culmination of all of these elements. But 3 factors of those 16 seem to dominate. They are cost, access, and quality. Demographically valid telephone surveys have been done by the American Medical Association of physicians and the general public for years. One of the questions has been, what do you think is the main problem facing medicine? In 1990, on the far right, 59% of the public and 40% of physicians named cost as the main problem. 6% of the public and 19% of the physicians named access as the main problem. Together, these two, cost and access, far outdistance any other named problem. Notice the change for physicians, the round black dots in the last 3 years. And also notice, remember, this is a telephone survey. And in telephone surveys, one of the things you get is you only talk to people who have telephones. And so a lot of people have problems with access to care in this country, also have problems with access to telephones, and that's why that doesn't show up anymore with the general public. But the percent of the gross national product we spend on medical and health care has been tracked in this country since 1929. At that time, it was 3.5%. Notice what happened in 1955. There's a jag up, and the slope hasn't changed since. That was 10 years before Medicare. Now, Medicare in 1965 maintained and maybe tipped the slope up a little, but basically the slope's been on the same slope since 1955, and nothing anybody has tried to do to it has had any effect on it whatever. It's become a sociologic norm for the percent GNP. This is not dollars, this is the percent of the pie, the total gross national product pie that's spent on medical and health care. Now this had caused a fellow named Donahue, not the TV Donahue, but a guy I know in California in 1979 to say that judging from the appearance of the doctor's parking lot, a visitor from Mars would conclude that a modern hospital is a factory for converting sickness, suffering, and death into fancy foreign sports cars. And that was 12 years ago, when the percent GNP was more like 9.5. Because the opinion that costs are a huge medical problem is strongly held by leaders of industry, labor, and government, as well as by physicians and the general public, and because of concerns about whether Americans are receiving appropriate value for money spent, I do not believe that meaningful health care reform will come about unless it is tied to some form of cost control. Well, to what can we attribute these increased costs? There are at least 8 major elements, each one of which we could spend days talking about because they're very complex. For starters, just economic inflation generally. That's fine, we all know about that. The problem is medical and health care inflation, as long as it's been tracked, is double to triple economic inflation generally. Economic inflation goes down, so does medical and health care inflation, but it's still 2 to 3 times as much, including last month, when it was 3 times as much. Increased number of elderly. Well, we used to talk about old people over 65. Now that's the young old. The old are 75 and above. The old are 85 and above. And when I started giving talks on these related subjects some years ago, I used to say the fastest growing segment of our population is the over 85-year-old segment. That's no longer true. It's now the over 100-year-old segment. And with this, which is marvelous, costs, tremendous costs. Increased survival of tiny neonates, and to what kind of lives? And how can we predict that at the time? One of the biggest ethical problems around, and we have a lot of ethical problems, is what do you do with these teeny, 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 weeny little babies who years ago never would have survived, now they do, and to what lives? For some of them, terrific. For others, big problems for everybody. And very expensive. New technology, of course. We listed the 12 big things on the second slide. Fabulous technology. New York Times this morning. Positron emission tomography. Terrific things. You can watch a thought in your brain in color. Fantastic. In terms of heart disease, wonderful. I would assume everyone here has had their PET scan of their coronary circulation today before they decided on what they were going to eat tonight. I made that statement at Case Western Reserve in Cleveland a couple years ago. I said, you don't have to answer the question, but how many of you have had a PET scan of your coronary circulation? 3 guys raised their hand. No, I won't ask you, maybe more of you, I don't know. Okay, I haven't had it myself. I'd like to. It might be kind of fun. Professional liability, yeah, probably $25 to $28 billion of the $730 billion. Inappropriate uses, well, according to RAND stuff, probably no more than 30–40% of what we do therapeutically and diagnostically is inappropriate. Either too much, too little, or the wrong kind. As a guy who ran a hospital lab in LA with residents and interns running around by the thousands for 10 years, I would have put the number more like 50 or 60% of the lab tests that were ordered there just didn't need to be done. And I'm quite sure that's true. And it wouldn't hurt the patients at all to not have them. Inappropriate uses, yeah, there are. Increased number of providers, yeah, and they all come into the field with income expectations. And Canada, you've probably heard a lot about in terms of healthcare system. They have a big problem in Canada. Access is not the problem. You hear about the queuing up, sure, for some things. The big problem is inflation. Their medical inflation's out of control, and they don't know how to control it. And they've hooked it up to the increased number of providers as one of the reasons for their increased inflation. Heightened societal personal expectations. That's supply-induced demand. It's marketing, medical marketing. Magnificent. I was in Nashville last Monday. I'm reading in the Nashville Banner. They have a section on health, really quite nice. And they were analyzing there the 9 hospitals in Nashville that you can go to have a baby. And they were comparing and contrasting why. And the hospital administrator, one of the hospitals, said, well, we don't compete by price because the insurance companies, they pretty much take care of that anyway, so we compete by services. And one of the main indicators in Nashville as to the best place to have your baby is the ratio of jacuzzis per rooms and beds in their labor and delivery area. Now, maybe you have a high jacuzzi bed ratio here and you're proud of it. I really don't know, but I almost threw up. That's ridiculous. I love babies, I love women, I love pregnancy. I want that all to be taken care of, but really, because the insurance company can pay for it. They all also were competing on what kind of goodies they had for the babies and what kind of carts they had to go along. That all came out of part of the deal to get them to come there, 9 hospitals. Well, increased societal personal expectations. Taj Mahals we have around for sick folks to go to. Well, how might one control? Of course, there are a lot of other reasons. Heroin, cocaine, alcohol, tobacco, AIDS, violence, lack of gun control, all that kind of stuff adds tremendous cost, no question about it. How might one control costs? Well, you start looking at the causes. Then you figure out how. And it ain't easy. It's hard. But here's some of the options. I'm not proposing any of these. I'm just saying these are possible. Clinical guidelines or parameters. That's the big push these days. Clinical guidelines or parameters. And that's terrific. My personal view is that this will be wonderful for quality and not much for cost control, but we haven't proven that yet. Organized medicine says it's for cost control, and we'll see. Patient choices for spending options. I think that patients should know what it's going to cost for something to be done. And I've conceived the idea of the economic informed consent. Now, out of the Nuremberg war crime trials came informed consent for research subjects who were humans. Tell them what they're going to do before you become a guinea pig. Okay? That was extended by ethics to tell the patient what you're going to do before you treat them and get their permission, informed consent. I suggest we take it the next step, which is tell them what it's going to cost. Somebody, because it's all society's cost. And the great thing that would do if we did it was the doctor would have to know what it cost. Of course, if your hospital is anything like the hospitals I know very well in California, you don't really know what it costs. You just know what you charge. And you know you charge at least 5 different charges for the same thing for different people, depending on who pays for it. Is that illegal? No, that's legal. Is it immoral? I'm not sure. Keeps the hospital afloat. It's called cost shifting, which is really charge shifting. But you'd have to know. So you'd have to have a real super course in economics for the doctors to teach them how much it's going to cost for this lab test or this x-ray or this number of days in a hospital or this length of time in the operating room, etc. High deductibles and high co-payments. That's, of course, what's happening now in all the companies. And the #1 cause for strikes in this country now is health benefits. Because the companies want to lay on to the patients, the employees, high deductibles, high co-payments, and stop covering the families. The Chicago Symphony Orchestra this year went on strike. They wouldn't start the season because of health benefits. Looking at it selfishly, fortunately our tickets were still good when they came back off strike, so it wasn't a problem. But that's there. This is one of the places the thing's going to blow up. Now, pre-use approval can mean before any technology is approved, like PET scans, or it could mean for high-ticket items on a case-by-case basis. Marketplace competition managed care, that's what the New York Times says is going to solve all the problems. In the JAMA in about 2 weeks is the experience in California with an editorial by Alan Enthoven that says, well, maybe a little bit, but not so well. Limiting the number of the physicians, that's possible. That would be called professional birth control. Congressman Roybal from Southern California has proposed 5 years in a row in the Congress that there be a maximum percent of the GNP for health capped by law. Hadn't gotten anywhere, but it's there. It's there, sitting there as one of the 30 bills that are over there right now. You can have national or state medical expense caps. You can have expenditure targets of various kinds. You can have DRGs for all hospitals and all payers, not just Medicare. And you can have RBRVS for physicians for all payers, not just Medicare. And then there are a whole bunch of other ways you could do it. But these are 10 draconian, in some instances, measures, the sorts of things that a whole lot of people are thinking about at this time. With malice towards none, with charity for all, so spoke Abraham Lincoln in his second inaugural address, recognizing that he had no political consensus regarding either the constitutionality of state seceding or the morality of slavery being abolished. But he knew what was right and was able, through persuasive, often inspiring rhetoric, to conclude a bloody and divisive civil war and constitute the foundation for this great republic. Yet access to basic medical care for all of our inhabitants is still not a reality in this country. There are many reasons for this, not the least of which is long-standing, systematic, institutionalized racial discrimination. Since health insurance in this country has traditionally been based on employment, the relative lack of good jobs with full benefits that disproportionately affects blacks and Hispanics naturally manifests itself with fewer comprehensive health insurance opportunities for these individuals. In addition, Medicaid coverage by poverty line demarcations and physician payments are the lowest in many states that have the largest proportion of blacks and Hispanics. Mainstream private medicine, particularly in our large cities like Washington, D.C., Chicago, Illinois, and Los Angeles, California, to name three, has turned its back literally on the poor. Many physicians refuse to even see such patients, and I have hard, documented evidence to support my statement. So one of the problems we have is not caring for the poor. In the Holy Bible, John 12:8 says, "For the poor always ye have with you." Martin Luther King said, "It's not the length of a man's life that matters, it's the quality." And I suggest that we ration human life every day in our society by length, by access, by quality, by cost, and many other methods. We ration irrationally, but deliberately. Rationing is apportionment, often equitably, of scarce items in accord with need, a share as determined by supply, a fixed allowance per unit time. Since virtually no one is completely healthy on any day, the potential use of medical resources is endless. There will never be enough providers or enough money to give all possible care to everyone. Thus, we ration. How do we currently ration? By access control through pricing that does not discriminate between needed and effective medical care and unneeded or ineffective care. We ration by differing payment approval policies that function under widely differing rules and institutionalize such variations. By not providing sufficient resources for disease prevention, which results in unwanted teenage pregnancies by the thousands, millions if you wish, widespread initiation of tobacco addiction, and rampant sexually transmitted diseases. By insufficient transportation to appropriate facilities that affects rural and inner city areas alike. By absolute and relative shortages of organs for transplantation that lead to unnecessary deaths. By major variations in practice patterns between geographic areas without meaningful outcome differences, demonstrating a waste of resources. By ignorance of availability of services. By language and cultural barriers. If you saw our May 15 issue, Eli Ginsberg, the great medical economist from Columbia University, pointed out that even if there's health insurance for everybody, we still have problems with language and cultural barriers to necessary medical care. We accept social class membership as a deterrent for care. We are training insufficient minority health professionals, although this morning, information out of AAMC indicates that the number of minorities applicants to medical school is up 12% for next year. The first turnaround on that in a long time, and a healthy sign, but still very small. Insufficient primary care physicians. Most developed countries believe that the right mix of primary care docs and specialists is 50-50 by percent. In our country, 615,000 physicians. What percent are primary care docs? 35. Specialists, 65%. We got out of control about 15 years ago. We're still not under control. So we have excessive specialist technocrats, and I can use such a pejorative term because I'm one of them. I'm a pathologist. That's a specialist technocrat, and I'm an editor. How much more of a technocrat can you be? But nonetheless, too many. In that country to the north, they have a 50-50 split, and Quebec says it's not enough primary care docs. We need 60% primary care docs, 40% specialists. And the specialists go bananas. They say, that's crazy. Well, we need a lot more primary care docs, which, if they were practicing appropriately, could take care of a lot of our problems. I think every person in this country ought to have a primary care physician. Is that a radical idea? I think it's a normal idea. I think that physician could play a huge role in how people grow up. Who gets pregnant early? Who uses a condom? Who starts using tobacco cigarettes early? And on and on. Something like 25% of our people have no primary care physician at all. None at all. Quality, value for money is where it's all at, obviously. Quality is very difficult to define. It took Robert Pirsig hundreds of pages in Zen and the Art of Motorcycle Maintenance to define quality. And I'm not even sure he decided, although that's about the best book there is on quality. It's all about quality. Well, as an editor, I don't like something that's 300 pages long. I prefer a shorter definition of quality. So I use the American Society for Quality Control, which says, quality is the totality of features and characteristics of a product or service that bears upon its ability to satisfy given needs. Quality is needs-driven. Quality is satisfaction of needs. A person has a need, they get a service, it doesn't satisfy the need, it doesn't have the right quality. I think that's very, very simple. Well, how do we do on quality? Same AMA survey, main problem facing healthcare and medicine in this country since 1983. The public said quality was a problem. The highest percent was 16%. Now it's down to 7%. Physicians are down at 3%. Not a problem. Quality's good. I think quality's magnificent if you have access. If you have access. In 1985, I published an editorial in JAMA called Medicine, a Profession in Trouble, ? I pointed out a lot of problems that I was seeing about that time, and I suggested 11 steps that might be taken to reverse what I saw as a damaging trend. Well, we made a little progress on some of those 11, but not very much. So January 5, 1990, I published an editorial coining a phrase or a metaphor called medicine's rocking horse. In that editorial, I lamented that despite some progress, the question mark on the statement, medicine, a profession in trouble, had come off. There was no longer any doubt. We are deeply mired in questions of value for money spent. Outcome indicators do not demonstrate value consonant with the ever-increasing percent of the GNP spent on medical and health care, and government intrudes more every day, micromanaging routine activities in the physician's life, creating this tremendous thing called the hassle factor. Really bad. I don't have to tell you guys about that. You know it more than I could possibly say. Well, a millennium is defined, in addition to its biblical definition, as a period of 1,000 years. At the end of the 20th century, we will not only be entering the 21st century, we will also be entering the next millennium. I consider the 1990s to be an extremely important, even critical decade in the history of American medicine. I believe it is our opportunity, indeed our responsibility, to deliver this beloved old learned profession of ours into the next millennium as a profession and not merely as a trade tightly regulated by government like a utility or strictly as a business. I believe there is serious doubt as to whether we're going to be able to do that. There are powerful economic incentives operating to make the practice of medicine a business more than it ever has been. And there are powerful government incentives to interfere greatly in it as well. Unfortunately, when medicine operates as a business, it doesn't even use the better ethical principles of business, such as truth in advertising, the customer is always right, satisfaction guaranteed or your money back. Or, when's the last time you saw a hospital advertise, "We will not be knowingly undersold"? Nope, that ain't the way we do it. Medicine develops its own set of not yet defined pseudo-professional business ethics under which it operates, manipulates the system with great aplomb, successfully circumventing any control mechanism that anybody's figured out so far in terms of percent GNP and that steep slope that I already described. Now let's examine briefly some of the differences between business and professionalism. By definition, an entrepreneur is the organizer of an economic venture, especially one who organizes, owns, manages, and assumes the risks of a business, one that organizes, promotes, or manages an enterprise or activity of any kind. There's nothing wrong with that. That's a fine definition. I like entrepreneurialism. Well, what is a profession? The first three definitions are religious in a standard dictionary. The fourth one is a calling, requiring specialized knowledge and often long and intensive academic preparation, a principal calling, vocation, or employment. Obviously, physicians are professionals. Chris Castle has recently listed 10 features which distinguish a learned professional from others. These 10 are self-governance individually and as a group. Self-governance, okay? Service to the poor without expectation of compensation. You don't send a bill. Delivering quality, not ripping people off. Guaranteed. High level of learning. Autonomy of activity deserved. Altruism. In the old days in academia, a certain threadbare nobility. When I go back to universities these days, I say I don't see too many threadbare clinical professors around this place these days, and everybody kind of looks down. No, it isn't that way anymore. Self-sacrifice, that's still there many times. Heroism when needed. And a JAMA article in about 3 weeks will document the number of primary care physicians by percentage who refuse to see HIV-positive patients. And it is high. And an editorial on the same issue by the Council on Ethical and Judicial Affairs will say what's going to happen to those doctors, because this is a breaking an ethical principle that's thousands of years old, and also new, because the AMA established it about 3 years ago. And they're going to have very specific things as to who ought to be taking these docs to the woodshed and saying, you take care of these people, you cannot discriminate that way. It's unethical. That's heroism when needed. It's a part of being a professional. An ethical practice with public accountability. This is professionalism. Now, on the other side of the coin, silent Calvin Coolidge, when President of the United States, is remembered for one thing. He said, the business of America is business. Okay, that's true. Who can argue with that? The issue then is one of balance. And I call this balance medicine's rocking horse. I propose that there are two potentially balanced components. They are business on the one side and professionalism on the other. On the far extreme of business are the money grubbers, and on the far extreme of professionalism are the altruistic missionaries. I would suggest that they've always been there, and they always will be there. That this is a natural tension in the field of medicine, which is both a business and a profession. Chaucer wrote about this. And I would suggest that if we had an anonymous secret ballot everybody in this room could write the names of some physicians that fall in all four of those categories based on their own experience right now. Secret ballot, of course. Now, the issue is emphasis. Now, we know that some physicians may be impaired by alcohol, other psychoactive drugs, or physical infirmities. Ralph Crawshaw of Portland, Oregon, has proposed that some physicians may also be impaired by greed. And Ralph has suggested that these physicians be referred to the Impaired Physicians Committee of the County Medical Society so that they could try to work that out. Up to this point, that hasn't happened, although when Ralph proposed that there be an Impaired Physicians Committee of any medical society, it took about 10 years before it started, and now everybody has Impaired Physicians Committee and should. So when Ralph talks about something, it takes a while. The Oregon Health Initiatives, the entire Oregon thing now, is because of Ralph's idea about 15 or 20 years ago that has now come to the point of the experiment. So I don't know, maybe. I believe that we are at a time in our society's history when greed in the 1980s had become a dominant ethic. From Wall Street junk bond traders to some Midwest sports idols to many Southern California real estate developers, greed has been in fashion. Physicians are part of the culture in which they live, and hospitals are part of the culture in which they operate. They are not immune to the pandemic caused by the greed virus. And I believe that, of course, the greed infection may persist longer into the 1990s with medicine than with some other groups which have had their comeuppance in the last few years. For example, according to the New York Times yesterday, 25% of all the office space in downtown Los Angeles is empty. Well, that's a problem, substantial problem, unfortunately. I believe medicine's rocking horse is tipping badly, and it seems to be tipping more every day. If it tips too far, it will fall, and it will take a very long time to be set right. But be it a clock or a human behavior pattern, a pendulum swings and a rocking horse rocks. We must stop this rocker before it tips over. I would like us to enter our next millennium with the rocking horse looking like that. How can we make that happen? Well, maybe we can't. Maybe it's beyond us. That's certainly possible. However, we may make it happen by calling a problem what it is, by appealing to the fundamental good that rests within almost all who were originally attracted to medicine as a service profession, by demanding that professionalism means self-governance, self-determination, and self-policing, and then doing it in good faith. During the greedy 80s, we as a society experienced, on top of all-time record federal budget deficits and international balance of trade deficits, an embarrassing savings and loan debacle and a Wall Street junk bond collapse, each predictable and each preventable, and each because they were not prevented, having massive long-term federal budget implications and a lot to do with the sorry state of the economy and the way it is at this time. I believe we are now poised near the brink of the 1990s healthcare system meltdown. If business as usual goes on without change, I believe by 1996, meltdown is likely. Now, in the worst case scenario, if that were to happen, the Congress would panic and has the authority to nationalize the healthcare system in this country. That means conscript the doctors, nurses, and pharmacists. It means assume authority over all hospitals and put the private ones out of business, nationalize the health insurance company and abolish it, and so forth. I think that's the worst possible thing that could happen. And of significance, of the 89 articles I received for consideration about health care reform earlier this year, of which we picked the best 14, not one suggested the UK National Health Service system. No one's thinking that way. But I believe that physicians are professionals. I believe they're different from the business people in savings and loan and Wall Street businesses. We know that learned professionalism means self-governance, self-determination, and ethical behavior in the public interest. I believe that to merit still being called professionals, we physicians intend to prevent any such anticipated meltdown in advance by proper preventive, scientific, educational, and political action now. The future, of course, is very difficult to predict. A lot of people don't even understand the present. As you can see here, all those things, those little blobs out there are congressmen, and the elephant in the middle is the healthcare system that they're trying to understand. The blind men trying to understand the elephant. Those of you who read JAMA might be interested to see how we decide what articles to select for it each week. We use elaborate and rigorous peer review. I have 8,000 peer reviewers in our peer review file, and they make all these recommendations. We use epidemiology, statistics, and then twice a week we get together and decide what's going to go into the journal. And that's how we do it. There we are, predicting the future. It's easy. And the times, they are changing so fast, dizzying. What to do? What to do? And yet, the more things change, the more they remain the same. Traditional, professional, and human values do not change. On May 15 of this year, we published what I believe will turn out to be the most famous JAMA issue of 107 years, dedicated to caring for the uninsured and underinsured. With that issue, all 9 of our specialty journals also ran articles on the same subject, and these articles have all been aggregated together in 300 pages of the best thinking America could provide at one point in time on healthcare reform and caring for the uninsured and underinsured. 300 pages, 10 journals. No other group of journals in the history of the world, best I can tell, have ever done anything like that. 10 journals, same subject, same time, all original material. We took the country by storm, a media blitz, and all that in May, and it's been moving very nicely since then. In some ways, too fast. Do we have a crisis of the uninsured? The special problems at this time, 31 to 36 million people with no insurance at all at any one time. 50 to 60 million un- or seriously underinsured. Medicaid covers only 40% of the, by definition, poverty population. When Medicaid came in 1965, it covered 75%. Now it's only 40%. And surprisingly to many people, 85% of the completely uninsured are employed or are family members of employed people. A lot of them are employed in low-level jobs, part-time work, contract work, or what have you. And a substantial percentage of people who work in the healthcare industry are uninsured. That's been documented. A substantial percentage of people who work in the health insurance industry are completely uninsured, and that is documented. Why do we have a crisis now if there is one? Well, we recognize it because there's a lack of insurance coverage we've now shown without question leads to poorer health and higher death rates in people sick with the same disease. We published that in the last year. Care is given by disruptive institutional shifting of costs. The costs are not there, they're there. They're simply covered in entirely different ways and more expensive. If you saw the report from Boston and JAMA 2 weeks ago, patients who come in admitted to the hospital because they present to the emergency department cause much greater costs for the hospital, way more than the DRG will cover in that situation, and it's a losing proposition for the several hospitals in Boston in which this was studied. Of course, the pragmatic hospital administrator would say, simple answer to that, just close the emergency room. And all over Los Angeles, that's what they did. So let's hope it's the hospital administrator who has the first automobile accident and doesn't have any place to go because his or her emergency room is closed. That is not the right answer. Employer coverage is inconsistent, and right after I finished the David Brinkley show, Washington back in May, one of the producer assistant types who'd taken me in for makeup and all that stuff said, "Thank you for doing what you're doing. ABC TV across the river in Washington has taken us off employee status and put us on independent contractor status so they don't give us any benefits." Poor care leads to greater costs long term. I already mentioned that. And rationing by access control erodes the moral standing of the total American community. And it's all getting worse, palpably. In Bob Blendon's editorial in our May 15 issue, satisfaction with health care, 1990 figures in there, all kinds of polls about this. Satisfaction with their own care, we had a high rating. 55% liked it. Satisfaction with the current system, 10%. That means 90% not satisfied. In contrast to these other things. And we published 2 weeks ago from Hopkins, Barbara Starfield's piece, comparing 10 Western developed countries on 3 main objective measures. And I'm sorry, but the US of A came out last of the 10. Next to last was West Germany, and third from last was the UK in terms of all those. 2 weeks ago in JAMA. Now, although there may be a consensus finally in our society that we must provide basic medical care for all of our people, and I do believe we have that now, we don't have any consensus at all on how to do it. Nor are we likely to meet consensus on that. It's too complicated. It's too difficult, and there are too many extremely powerful vested interests on all hands. So we must not wait for consensus. We won't get it. In successful health care reform, every segment of our society will have to give up something. Some quite a lot. Starting with the patients. They can't have first dollar coverage for everything. No way. It'll break the bank. The doctors, in many ways. The hospitals, there are too many of them. Far too much supply. Way too many beds. 40% maybe overbedded. The insurance companies, frankly, their survival is in question. I'm not talking about life insurance, I'm talking about health insurance. What are there, 1,600 of them? And if you need health insurance the worst, you can't buy it. And if you don't need it, they'll sell it to you. That's called risk-based insurance sales. That's crazy. It's absolutely immoral, and it has to stop. There have to be community-based premium rates, not risk-based. It's what's called bass-ackwards when I grew up in Alabama. At least that's what we called it. The administrators, the politicians, and all the other stakeholders are going to have to give up something as this thing works out. Now, in our issue in May, we had 14 major proposals. And in the Blendon editorial, they analyzed the proposals on these particular grounds: scope of coverage, type of administration, financing, provider payment, cost containment, long-term care, reinsurance, and catastrophic coverage. And some of them did all this, some of them only did some of it. Most of them didn't deal with long-term care. And those of you who are really interested in that, we all ought to be interested in that. In the JAMA, in 3 weeks, there's the first major proposal on long-term care and how to deal with that as a country. A long 7-page JAMA article, about 3 weeks. Now, looking at the 14 proposals, analyzing them, type 1, which was compulsory private insurance through employers with government insuring non-workers and the poor, there were 5 such proposals. Type 2, law requiring employers to provide private insurance to employees or to pay equivalent tax with the government insuring non-workers and the poor. There were 4 of those proposals. Type 3, tax credit for purchase of private insurance. There was 1 of those. And type 4, which was all government insurance system, more like the Canadian system or something like it, never like the UK system. That wasn't proposed. There were 3 of those in the JAMA issue. I personally have no problem with Uwe Reinhardt's approach saying, hey, we should have basic economy class that everybody's guaranteed. We can have business class if the businesses want to pay for it. And then there's boutique class for Ross Perot, Lee Iacocca, and anybody else who wants to pay the money for the boutique class. And you can have hospitals for boutique class. Or I was in Birmingham addressing the Jefferson County Medical Society a week ago last night, and they pointed to me and wanted to show me, and I said, no, I just do not see it. The top floor of the cardiac surgery area. It's a fabulous place. It's there for King Fahd, for anybody else like that who wants to come to have the giant super boutique care. Beautiful, they'll pay for it, no problem. But don't take my insurance money to pay for that, okay? And don't take it away from the folks who can't even see a primary care doctor or have their pregnancy taken care of with prenatal care, which is the case now for large, large numbers of people. But I don't mind this. We're a capitalistic society. I hope we stay capitalistic. We're pluralistic. I hope we stay pluralistic. But let's at least do basic economy class for everybody. Now, we can succeed in this whole thing. It is not hopeless. As a matter of fact, we must succeed, because not to decide is to decide, and the thing's in a runaway situation. We have to succeed. We can succeed from the editorial has some of this. It also has the next paragraph, which was read as part of my introduction, which I indicate that a long-term crying need has developed into a national moral imperative and now into a pragmatic necessity as well. An aura of inevitability is upon us. It is no longer acceptable morally, ethically, or economically for so many of our people to be medically uninsured or seriously underinsured. We can solve the problem. We have the knowledge. We already have the resources, the skills, time, and the moral prescience. We only need clear-cut objectives and proper organization of our resources. Have we now the national will and leadership? Those who heard it can never forget Douglas MacArthur's farewell address to the Corps of Cadets at the United States Military Academy in 1962. As he came near the close, General MacArthur said, "My last conscious thoughts will be of the Corps and of the Corps and of the Corps." So must the dedicated physician's every thought be of the patient and of the patient and of the patient. That must never change. And let us remember that the enemies of physicians in 1991 are not the profit-making companies, not the congressional or state politicians, not the government bureaucrats, not the insurance companies, not the hospital administrators, although we could all find fault with some elements of all those groups. The enemies of physicians are certainly not other physicians, no, not even the attorneys. The enemies of physicians are and will always be premature death, disability, disease, pain, human suffering. All that other stuff is nothing but noise. Dizzy Dean, the famous American baseball pitcher who became a radio announcer after his playing career ended, used to say, when the bases were loaded and nobody was out, "The ducks is on the pond." I say that the bases are indeed loaded.